All right, so we'll start with some introductions. Manny, do you want to start us off? He's in the middle of cooking
Yeah, sorry,
lunch.
I was muted. Joyce, sorry about that. Hey guys, I'm Manny Singh. I'm the clerkship director at Harbor. So hopefully I will see some of you guys. If you guys are interested, we definitely do have some spots that are available later in the fall months. There is a wait list for the earlier primetime months, but please, 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 come rotate with us. It's a great rotation, great residents like Joyce, Leolia, Sahar, and Caesar who are on right now. But I'll leave my contact information in the chat. I have to cook my wife some dinner. I forgot that this is tonight, so I'm gonna go work on that while before she gets here. But please, please do feel to reach out to me if you have any questions, even for mentorship or anything like that along the way. I'm always happy to be a source of info for you guys. So thanks, guys.
Yeah, thanks, Manny. Thanks for hopping on. All right, Caesar, you want to jump in next?
Yeah, of course. Hey, everybody. My name's Caesar. I'm one of the PGY2s at Harbor. Like Manny said, I also did a sub-I at Harbor. 100% recommend. In the age of Zoom, when you're applying for residencies and everything, it can be a little bit difficult to see how a program really fully functions from the inside. So doing a sub-I, or an away rotation is definitely a prime way to to really find out what that program is about.
Great, thanks, Caesar. Leolia, do you want to introduce yourself next?
Hi, everyone. Welcome. My name is Leolia. I'm one of the third years and incoming chief resident. Not everyone that goes to Harvard did a sub-I, but I think it is a testament to the people that rotate here, tend to really love and enjoy the program. And we're happy to meet you all, and I'm sure we'll continue to see you throughout the application cycle.
All right, great. Tiffany, you want to introduce yourself next?
Hi, everyone. My name is Tiffany. I'm one of the second year residents. I also rotated at Harbor. I was actually a UCLA med student, so I did all of the rotations at Harbor. So that's adult EM, PCM, and ultrasound. So I'm happy to answer any questions you have.
Yeah, Tiffany loves Harbor. It's great. All right. And then next up we have Sahar, if she wants to say hi. She's actually wrapping up a MICU shift, but she wanted to join in to say hi as well.
Hey, I'm Sahar. I'm on MICU. That's my intro. I'm on PGY1. Bye, guys.
And Sahar also did a sub-I. So we have all these former sub-Is, which is fantastic. Yes. All these former sub-Is, which is fantastic. I personally did not actually end up doing a sub-I just because of COVID. We were the year of COVID, had like a couple rotations set up, and then the world went to hell. And so all the rotations got canceled. But without further ado, let me share my screen. So we'll talk about today about kind of like nuts and bolts and like tricks and I can't even talk. Tricks and tips for how to succeed in your EM sub-I. And full disclosure, I'm post-night, so if I'm a little loopy, I totally apologize. And also, just with all of our webinars, please, 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 at any time, feel free to either unmute, raise your hand, or type in the chat. All of my co-residents will be kind of chiming in as we go through this presentation. And if you ask questions on the chat, they can even answer just directly in the chat. So we want this to be kind of interactive. If anything comes up, feel free to stick it in there. Sound good? Everyone on the same page? Fantastic. All right, so general timeline, right? There are kind of four main kind of parts to going on a rotation, right? There's kind of the part before your rotation, the start of your very first rotation, on shift, and then end of shift. So we'll kind of give you some like tasks and things to think about in each of these four phases. So before the rotation, first and foremost, get pumped. Like, you got an EM sub-I, fantastic. If you don't have an EM sub-I, as Manny mentioned, we have a few kind of later in the season, kind of in the fall and like winter season. So if you are interested, please, please, please apply. We definitely still have spots later on. But as soon as you actually have your rotation, like, oh, thank God, navigated VSLO. That was a hot mess express, but like finally figured it out. It was great. The second thing you want to figure out is kind of like knowing what type of hospital system you're going to go to. So this is actually very important, particularly for emergency medicine, because EM is practiced very differently depending on the practice site. So we at Harbor UCLA, we are a county site. We kind of say we're county site with an academic lens, but we are purely county. That means we're taking care of county populations. We're a safety net hospital. We're working with underserved patient populations. Versus an academic site, you might have kind of like all the consultants. It might be bougie, might be affiliated with the university. Versus a community site is going to be kind of more of your nuts and bolts ED, where they're a little bit more fast paced. They might see a lot of patients. They might have a little bit higher resources, kind of depends on the place itself. Also familiarize yourself with kind of the number of shifts you'll be working, the type of shifts you'll be working as well, just because kind of day-to-day might be a little bit different. One thing that I did that I'm so happy that I did before my very first EM rotation was I listened to this little podcast series called How to Crush Your Slow. I think it's probably from like, it's like 2016 or something, but I think his tips are still 100% relevant. It's this guy who runs something called the EM Clerkship podcast, Dr. Zach Olson. And basically he goes through 30 very specific things on things you should be doing on your rotation in order to stand out. So like kind of like how do you balance like the mental gymnastics of being a student where you're trying to impress, but like patient care, but learning, all those things he kind of like talks about a little bit. But he also says like, okay, like as a student, here's things you could do to be helpful. One, like make sure the patient's in a gown, like help them have a gown, help them get dressed, like make sure you're introducing yourself to the patient. Go back and reassess the patient. Make sure if the patient needs a urine, like they have a urine cup, they know that they need to provide urine because that's always a stalling point. So like little specific tips. And so I'm very glad that I listened to this. Definitely you don't all have to listen to it, but I thought it was very helpful for when I was starting my EM sub-Is. Another thing that you can consider for your phone, MD Calc is a fantastic app that has a few different kind of tools that we can use throughout your ED shift. So like we'll throw around like the heart score, the perk score, like things like that. Nexus, like different scoring systems that we use to help us guide kind of our evidence-based practices. It's a free app. It's pretty easy to use. So I would download this one. Another app that I would download onto your phone or at least have kind of readily available on your device, kind of on your computer while you're working on shift is Wickham. It's actually just WIKEM. This is a resource that was actually developed by Harbor, which is amazing. Ross Donaldson, one of our attendings here, he created Wickham, and it's basically an up-to-date, but like the condensed, dumbed-down version of what do you need to know on shift, which is wonderful for us ED docs because of our short attention span. So it's super duper helpful. I would definitely either download it on your phone or at least pull it up on your computer while you're working on shift. Next one, Hippocrates is another one that can give you some good medication resources. A lot of people use it kind of on their phone. It's like a quick guide if you're like, oh, what's the dose on that again? Or like, oh, do I have to change it for like renal function, or what's the best way to treat X? Like it's a good like on shift resource. And if you're doing a full like either month or 2 weeks in pediatric emergency medicine, you might want to consider PediStat, especially kind of more as you're going into residency. It is $5, but it's no monthly fee or anything like that. But it's a really good application because kids have a lot of nuances to them. And so it's nice that it gives you a quick and dirty guide of like, okay, if they weigh this amount or if they do X, then you need to give them this. And it breaks it down by either like disease, like airway interventions, seizure interventions, things like that. So just some on-shift resources that you can download, start to familiarize yourself with. Definitely don't need PediStat unless you're like starting in a Peds EM specific block, then you can consider it, but it's not 100% needed. The other three I would at least be familiar with. Another thing, don't get stressed out about having to know everything on day one. I feel like some of the sub-Is that come in, they're like, oh no, like I'm an advanced medical student, like I need to know everything. 100% not the case. Like we understand you are a medical student rotating in emergency medicine to learn emergency medicine, to get better at emergency medicine, to test out if this is what you want to do for the rest of your career. Don't worry, we don't expect you to know everything. So just come in with that mindset. Like, I don't need to know everything, but I'm going to come in with a growth mindset. Like I'm going to try and absorb and learn everything that I can while I'm here at this rotation. Try a couple different study strategies while you are on the rotation. You definitely want to be studying kind of throughout, just so you're continually improving, just as you have been doing for all of your previous medical clerkships thus far. So some podcasts, so we talked about kind of the EM clerkship podcast, there's EM Basic, all of these you can find on like Spotify or any podcast site. MRAP, it depends on your school. Sometimes they'll cover it for you, but it's like an EM specific podcast. There's a few different practice questions. Sometimes your school will cover it, sometimes not. So like Roche Review, I know some schools cover AMBOSS. There's like a little case files books that works through different EM cases as well. There's always UWorld, of course. So doing some practice questions are going to help you just to stay on top of everything. And you kind of figure out throughout it, you kind of know what works for you and what doesn't, and you adjust accordingly. And the more that you can connect what you're learning or what you're seeing on shift to your learning at home, the better. Like if you see a patient with DKA on your shift, like Sahar's about to go see, and you were able to go home, read up on DKA, you will always remember like, oh yeah, I saw that patient with DKA, they had X, Y, and Z, and you have that memory hook. So, and then also when it comes to a second DKA patient, then you'll like really shine because you're like, oh, I've seen this before. I know exactly what to do. And your presentation will be flawless. Okay, cool. So now we've kind of finished the prep kind of before the rotation. Now we'll start off and say like, okay, what do you actually do at the start of your first shift? First and foremost, show up early. Hospitals are really confusing. Like, I don't know why parking is always a hot mess and like trying to figure out where to go and then trying to figure out the doc box. So your very first day, make sure that you give yourself plenty of time to kind of figure out that whole situation. Showing up early is totally fine. Obviously don't show up like 3 hours earlier to your shift. That's a little weird, but like show up like, you know, like 20 minutes early. That's totally fine to try and figure out everything. Be nice to everyone you meet. This is probably the biggest tip I could give you, and kind of where some people maybe have a little bit of pitfalls. Don't just be nice to the attending. Don't just be nice to the residents. Be nice to any other medical students you meet. Be nice to the housekeeping staff, to security. Definitely be nice to your nurses. It's Nurses Week, by the way. So if you're on clinics, go give a shout out to your nurses. But be nice to everyone. It's going to help you, one, in the long term when you're a resident and moving forward, but two, it's also going to help you shine in your sub-I. A lot of these programs are pretty small. Everyone talks to each other. And so like, for example, if you piss off a program coordinator, that will come back in like the rank list meeting. So like, be very nice to your program coordinators, reply to all their emails, be timely, be very nice. Also, expect that every shift will be a little bit different. So the emergency department in and of itself is very kind of like chaotic and hectic. And so every shift, one shift you might have a lot of like really high acuity sick patients versus another shift, you might just see a bunch of like stubbed toes and colds. So it has a really wide variety, and to kind of see if you like that kind of wide variety, but also just something to keep in mind that one shift you might have like someone who's like also like the best teacher and really takes you in and teaches you everything, versus another shift it might be really busy. The attending and resident might not be as interested in medical education, and just kind of like go with the flow, you know, like every shift's going to be different. Definitely introduce yourself to everyone at the start of the shift. So like attendings, residents, making sure like your patients know who you are as well. And kind of don't like you read the room a little bit. If it's like in the middle of like a high acuity trauma, like someone just got like shot in the heart, you're not like, hi, I'm the new medical student, right? You're laughing, but like we've seen some of this stuff before where people like aren't able to read the room. So name of the game is always read the room, find a good time and be like, hey, I'm the new med student. I'm working a shift today. Like, I'm excited to learn, you know, just something like short and sweet. And they might be like, oh, cool. Where are you coming from? And you'll have a conversation that way. But, just introduce yourself. It's always also kind of awkward if like there's a med student just like sitting in the corner of the workroom and you're like, are they with us? Are they on another team? And like they never introduce yourself. So that's also a little uneasy. If it's not busy, also ask at the start of the shift, if you can, kind of what are your expectations of me of this shift, or kind of say like, okay, like I worked a shift with you before. I would really like to work with X. We love it when you have like specific goals for the shift because we'll really try and tailor your shift to that goal. So if you're like, hey, last time I saw a patient with like an endocrine complaint about like diabetes, and I'd really like to either see something different or see something more complicated. I mean, you can kind of figure out kind of what works best for yourself, or maybe in your reading, you saw something that you're like, oh, I would really like to learn about the management of acute chest pain in the emergency department. Like I would love to have a chest pain patient so I can do that thorough differential and everything like that. And lastly, see patients. Your sub-I is your chance to like really try and like see patients, like do your history, do your physical, always do full physical exams, and then come up with an assessment and plan. So we'll talk about that a little bit. Once again, be nice to everyone, absolutely everyone. Great. So on shift, go to the excitement. So that's probably my number one tip in the emergency department. If you're on a team and the team gets called to a critical medical, a trauma, a new ambulance run, things like that, be there. Like go there, get exposure. It's not always going to be like a super exciting case, but you want to be there to get as much exposure as possible. And there's a lot of things that you all can help with throughout. Like when a new trauma comes in, we always want to get exposure. So if you're able to help take off their shoes, have trauma shears on you, cut off their clothes, get exposure, get them warm blankets. There's little things like maybe your first time kind of be a little bit more of an observer and kind of figure out what people are doing and where they are, and then jump in afterwards. But go to the excitement. They will give you specific guidance within your each sub-I about kind of what's expected of you and what you should and should not go to. But in general, if you go to the excitement, that's good because one, that shows that us as residents and faculty, we're like, oh yeah, they're excited to be here. They're coming to help out. They're trying to be hands-on. They're trying to get exposure. Versus two, if someone's just like has their one patient and they're just like working on their note and like the entire team is doing like a resuscitation and compressions, we're like, oh, where's the med student? Like this would have been a great learning case, or like they could have helped us with CPR. Picking up patients, every program will do it differently. Some programs, they will have you like be paired up with one senior resident and your senior might assign you patients, or you might be working with faculty directly and they might find you patients. Or if it's just like an open board that you're seeing the board and you see a new patient come up, maybe you're like, hey, that patient seems interesting. Is it okay if I take them on? Just kind of feel out the vibe. You can ask kind of more explicitly early on and be like, do you want me to actively sign up for patients, or do you prefer to assign me patients? Review the chart a little bit. We're not internal medicine. We don't expect you to do a super deep dive of every single chart that comes in. And also we want you to kind of like go there and see the patient, especially if they ever have any like vital sign abnormalities or anything along those lines. You'll get a lot of information just from the patient themselves, and you can always do a little bit more chart digging on the back end. So review the chart a little bit before you go in, see the patient, and then come back and you can always review the chart a little bit more. We love undifferentiated patients in the emergency department. That's our bread and butter. People come in with complaints and then we try and figure out diagnoses. Versus internal medicine. Like if you're getting an admission, typically the ED has figured out a general admission for like why they're coming in, or a general diagnosis that might change over the course of their hospital stay. And so that's something we really pride ourselves in, is like think broad. We kind of want to think about kind of the most likely thing it's going to be, the thing that might kill the patient because they're here in the emergency department and we want to know what's going to kill them the quickest, and maybe something interesting that it could be. And then the visit itself, introduce yourself to the patient, do the history of the physical. We'll talk a little bit kind of about presentations also, like ED style presentations. And then this is a really big one here at the bottom, is reassess the patient. So if you have your patient, like let's say you picked up a chest pain patient, right? You present it to your resident and you say like, hey, they have chest pain. It's reproducible on exam. They were lifting heavy furniture yesterday. The scary thing is that it might be like a heart attack, but luckily we got some labs and EKG and a chest x-ray, and it doesn't show that any of that pathology is happening. But I think it might be MSK. I was going to give them Tylenol and reassess them, right? So maybe that's like your general plan. This is like a very shortened, abridged version of a patient I saw just a few hours ago, right? So you'll have your resident order the Tylenol, and then you got to come back like maybe like half an hour, an hour later, go back and see the patient again. Be like, hey, how are you feeling? How was the Tylenol? Like, did it help? Did it not help? How are you feeling now? And then if you come back and you tell your resident like, hey, good news, like his pain's completely gone. He's feeling comfortable to go home. Things like that. That really helps us because we're like, oh, great. We know that the treatment worked. We have like a good follow-up plan and things like that. Same happens with like sicker patients, right? If they are a little bit dehydrated, hypotensive, obviously we're not going to like just throw you off into the deep end and give you a super critically ill patient. But if you're part of the care team for that patient and be like, hey, we gave them a liter bolus and their blood pressure went up a little bit, or like, oh, they're feeling better after we gave them X. Like just going back and seeing the patient again shows to us that one, you're investing in that patient care. Two, you can see kind of the course of their disease and how they're progressing, which is helpful. Picking up patients once again, ask if there's anyone to see versus they might just assign you from the start. And also like, we don't want you to be too eager if that makes sense. So we don't want someone who's like hunched over like the resident who's like, are there new patients? Like, what can I do? What can I see? What can I do? Like, it's like a delicate balance as a medical student where it's, you want to be helpful, you want to learn, you want to have a good experience, but trying to have that balance of being like, okay, like if there's no one to see currently, like knowing to be able to take a step back, maybe look up stuff on the side, things like that. And also you'd have times to maybe like walk around and familiarize yourself with the unit, introducing yourself to other staff like nurses, trying to get your nurses' names, things like that. And then trying to see also if anyone needs help with like simple procedures like laceration repairs and trying to get exposure that way. And once again, be proactive. If there's something you want to see, like let us know. Be like, I want to see chest pain, I want to see abdominal pain, things like that. Be proactive, read the room. Read the room. Honestly, if there's one thing that you take away from this entire presentation is read the room, right? If everyone's like super high intensity, then like maybe take a step back. If it's a little bit more chiller environment, you could take those time and like ask questions and get involved that way and ask for expectations and things. On shift, reviewing the chart. Once again, you don't want to spend too much time doing the chart review. Review the vitals. This is something that we'll always want you to know in your patient presentations and are incredibly important for emergency medicine room patients. So if the patient looks sick, they have abnormal vitals, like ask a resident just like, hey, I just wanted to run this by you. Like, I see that their heart rate is 110. Is that something I should be worried about? And the resident might be like, oh no, that's totally fine. Or like, oh yeah, maybe like, let's pull up their EKG. Oh, they're like actually bouncing between 120 and 140. They're in AFib with RVR, and it might be a different conversation. And if you're ever unsure, just ask. And then also if you ever like see a patient and they look like they're dying, they're probably dying, and you should probably grab someone that can put in orders and also help you out. So if you're ever like your spidey senses go off, like, oh my God, this patient looks actually really sick. Like, for example, if it's like a shortness of breath patient and they're like giving you the history, but it's like one word at a time and they have to like gasp for breath every other word, then it's probably time for some interventions. And you can always like, after the interventions, go back and get more of a history, but just say like, be like, hey, 1 second, I'll be back. And then talk to your resident, be like, hey, this person looks a little bit sicker. Are you okay just laying eyes on them? I just want to make sure that I'm not like we can try and help, like maybe do some interventions, or like maybe we need to give them some like duonebs or breathing treatment before we talk to them more. And your residents will never fault you for that. The thing that scares us is if we like send a medical student to a room of a really sick patient, they don't recognize that they're sick, they stay there and they get like a history for ideally like 10-15 minutes, but it goes on for like 30-40 minutes and the patient just continues to decompensate. And then the student comes to us and they're like, hey, this is my presentation. And on exam, they're sitting at 70% and gasping every word. And you're like, oh my God, like, let's go see the patient right now. So grab us if you're ever concerned. When you're talking about oh yeah, just things to know when you're walking to the room, kind of main chief complaint. And then you can start thinking of some differentials. And knowing what questions you're going to ask, as well as what physical exams you're going to do. And there's some resources online to help kind of guide that for the main kind of undifferentiated patients. Such as we talked about this. Great. Developing differential based on the chief complaint, and then also developing your history and physical exam before you see the patient, like a game plan, not necessarily like trying to put them into a bucket, but kind of still staying a little bit broad going in, but having an idea of like, oh, I know that a patient with chest pain these are the things that might kill them, like an MI, pneumothorax, PE, things like that you might be like thinking of. At the end of the day, it might be musculoskeletal, but you want to think about all those things and be like, have I tested them for it? Do they need additional testing for me to rule it out? The whole visit in and of itself should ideally take 10 to 12 minutes. Every patient is going to be different. If you're needing to use an interpreter, it's going to be longer. If they have a really complicated past medical history or their story doesn't make quite sense and you're spending that time getting collateral, it's going to take longer. But like a cut and dry, like ED patient visit, your goal should be 10 to 12 minutes. It'll be longer when you first start and you'll get more efficient as you go. We don't want you cutting corners or missing important information, but that should be your goal kind of throughout your sub-I to build into it. Rapport building, definitely important. Try and connect with patients as much as possible. Asking focused questions to kind of do it based on your differential. So for example, if we go back to that chest pain example, like pneumothorax, like let me ask specific things. Be like, oh, did you have any like traumas, for example? Or have you ever had like a pneumothorax in the past? Or did we order a chest x-ray? So like in the emergency department, you're thinking about this differential and you're asking specific questions and you're doing specific tests to rule things in or rule things out. And then as you're going through it, you're going to kind of think about your differential again, be like, what can be moved up? What can be moved down? And then making sure that you're performing your physical exams. Always, 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 like every patient visit, basically listen to their heart, listen to their lungs, press on their belly. I know that they're here for like toe pain, but as a medical student, we'll still be asking you questions about the other parts of their physical exam. And you never know what you might find. Be like, oh, they came in for leg pain, but I pushed on their belly and it was like peritonitic. Like you never know. So always do a full physical exam in addition to the focused ones. And then bedside ultrasound. I know some med schools are a little bit better at bedside ultrasound than others. My med school did not prepare me at all for bedside ultrasound, but if you've learned some of those skills, being able to be like, oh yeah, like they're here for shortness of breath. I took a look at their heart and they actually look like they have a little bit of poor squeeze. Like we love hearing stuff like that. You're taking initiative to look at ultrasound. If you've never touched an ultrasound in your life, be like, hey, I'm interested in learning more about ultrasound, and you see a resident that's going to go do an ultrasound, be like, hey, can I come with you and just try and get exposure that way, or try and do an ultrasound dedicated rotation. All right, the presentation. EM presentations are unique. We like things that are streamlined. We like things that are condensed and concise. Anything longer than like a few minutes, honestly, sometimes we like zone out. You want to be able to get all the information out, but it's got to be like kind of streamlined in the sense. So at the start, give the one-liner. This is a patient with X medical history. They are here for X. And then also you can kind of say like, I'm worried about this patient if they think that they're a little bit sicker. And then you give the meat of your presentation, right? Your HPI or past medical history, aggravating, provoking factors, all that. Your exam, you always want to state your vitals right before your exam. Be like, they're afebrile with stable vitals, or, you know, like they're hypertensive to the 160s. Systolic. And then your exam, like heart, lungs were clear, you know your basic exams. You don't have to give like the whole medical, like the medicine, internal medicine presentation. Be like, the heart had no murmurs, rubs, or gallops and was great. Like be like, okay, the heart was regular rate and rhythm. Next, like the lungs were clear to auscultation bilaterally. Next, like, kind of like the short version of those, like those phrases that you learn while you're on internal medicine. And then the differential. So we want you to try and commit to an assessment and a plan. Be like, I think this person has X and I want to do an x-ray, I want to do labs, I want to do an ultrasound. Like you don't have to know for sure, but we like it when you try and come up with an assessment and plan, because that also will push you to be better. You can see like different people like their presentations a little bit differently. So you can always ask the resident attending, be like, hey, do you want me to have like a full thought out plan, or do we want to, or would you rather me like kind of discuss it more with you? Obviously you're not putting in the orders. Like it's not like if you're like, oh, I think this person has a heart attack and we should take them to the cath lab. They're not going to be like, all right, activate STEMI immediately. So like they'll talk to you, they'll say like, okay, why do you think that? And you yourself will get better learning if you yourself are like, I'm going to commit to a plan. Like I'm not 100% sure, but let me say like, I think it's this, my plan would include this, this, and this, and then you'll talk about it. Include any pertinent clinical decision tools. So we love these in the emergency department. So MD Calc is an example of that. Like say you have a patient with chest pain and you use the heart score, and the heart score comes out to be 6, right? Maybe they're having like exertional chest pain, they're 70 and they have a history of diabetes, high blood pressure, and their trope is a little bit up and their EKG is like not great. You might be like, yeah, so this patient seems like they're going in. For like the kind of the middle patients where you're like, you know, like I don't know if they're coming in or not, and then you see like their heart score is 4 and their story is actually kind of concerning, you might be like, okay, I saw the heart score was 4. I would like to admit this patient for further cardiac risk stratification. The fact that you're kind of thinking about kind of where the patient is going, like dispo, we love disposition. So is the patient going home or is the patient coming in? And being able to use these clinical decision tools to back up what you're talking about is always helpful. And then lastly, like kind of the conclusion, like we talked about. So like, what's your plan? And try to have a plan with every patient. Every patient is going to be different. Some are easier than others. And then there's also this kind of the EMRA 3-minute how to present video. And so you can just Google that and it kind of gave you a little bit more tips and tricks on how to do a good EM presentation. All right, cool. Once you've actually seen the patient, don't feel forced to present your patient right away. So like sit down, gather your thoughts. Sometimes I'll see medical students, they like see a patient, they're literally coming right back to the workroom and they're like, I have a patient to present, they have chest pain, I think it's GERD. And you're like, whoa, like take a moment, you know, like formulate your thoughts a little bit. And we'd rather have you have like that succinct presentation and kind of think about your differential a little bit more than just kind of blurting things out. And then after you kind of do that little back thought, maybe look up something, a thing or two, then you'd be like, hey, resident or attending, I saw the patient in room 3. I'm ready to present whenever you're free. And that'll also say like, okay, let me finish up this, or they'll be able to jump right in and hear your presentation. And always ask people like, like even at the end of your very first presentation of that shift, be like, how would you like how can I improve my presentation? You know, like kind of try and continuously elicit feedback when you can. About how you can improve throughout the shift, as opposed to just like waiting for feedback at the very end when they didn't know you wanted like a ton of feedback and they're like, oh, you did good. But if you give them something specific, like at the end of a presentation, be like how can I improve my next presentation? That gives them something concrete they can focus on. Maybe they'll be like, okay, let's have you present another patient. I'll give you feedback on the next one. Once again, as sub-Is, you're expected to try and come up with a plan, but it's okay to be to be wrong. We're going to expect you to be wrong, like a lot of the time, to be honest, because you're still learning. Just try and commit to a plan if you can. And then some people like the SPIT model. So like, what is the most serious thing it could be? So what's going to kill the patient? What's the most probable thing it could be? What's like really on the top of your differential? What's something interesting it might be? And then what is the treatment plan? So SPIT. So chest pain, for example, like I think we need to rule out a heart attack and a PE. Most probable, it's probably like a musculoskeletal pain. Something interesting it might be is, I don't know, a weird cancer, fungating mass, something. And then my treatment plan is X, Y, and Z. You'll see if you like this kind of general model, but at least it's things to think about. The first two, the serious and probable, are going to be things you definitely want. The interesting one is like plus minus. Some people really like giving a little interesting one, but not always necessary on your presentations. Okay, once again, reassess the patient. This is something we talked about before. Reassess the patient's symptoms. Do the medications help? Are the vital signs improving? Also, if you ordered some labs and imaging as part of your plan, check to see if they came back. Be like, oh, I saw the x-ray, the lungs are actually clear. Oh, it looks like they have pneumonia. If you come back and you say like, hey, I looked at this imaging or this lab, it looks like it's abnormal. We're like, oh, great. They're like continuously looking at the chart to take care of that patient, because that's something you're going to do as a resident, as an attending, and onward. And continually reassess until a disposition is made, until they're like, okay, we know they're going home or we know they're coming into the hospital. And then also, if you decide that ultimately they are going to go home, think about what their discharge plan is. For county patients, for example, here at Harbor, we have a lot of underserved patient populations that come from a variety of backgrounds. Think about those barriers about like, oh, like I want them to follow up with their primary care doctor. Well, 1, do they have a primary care doctor? 2, have they been to them before? 3, can they make an appointment? 4, do they have a ride to get to that appointment? So having those conversations with your patients and figuring out what are their barriers to accessing care is very helpful, because if, for example, if you have a patient say they're experiencing homelessness, they have like a bad leg infection, like, am I worried that they're going to be able to actually pick up their antibiotics? Is this infection severe enough that I was actually considering admission? Like he's kind of on the fence to be admitted with IV antibiotics or discharged with PO antibiotics, but I found out he is unable to pick up his medications for X, Y, and Z reason. He has all these barriers to care. We might end up leaning towards admitting the patient. So kind of thinking about these additional things like, do I have a safe discharge plan that the patient can actively follow up on? That's going to be your biggest thing if you are discharging a patient. And we love hearing it on in your overall plan. If you kind of get through your presentation and at the very end, you're like, yeah, this person, like I was able, like I think we should consult social work in order to set up like a ride for them or try and get X, Y, and Z done. We love that you're talking about those social determinants of health because they are so, so, so important to our patients' care. All right, cool. We made it to the end of the shift. Whew. What a whirlwind, guys. Before the rotation, first shift, end of your shift. Asking for feedback. Throughout is better, but definitely at the end, be like, hey, what are things I can improve on? And then take what they say and really like commit it to heart. I mean, obviously sometimes people just give you straight up bad advice, which is a different story. But if they're giving you like good advice and they're invested in your learning, really try and take what they say and continually improve throughout your rotation. And really apply it to the next shift. Because if you work with that same person again on your next shift and you apply what they said, they notice that. They're like, oh yeah, we said I wanted them to reassess the patient more. And then with this patient, they reassessed the patient 3 times. They had a great plan. So we love seeing people who are teachable. Teachable is like a huge thing for what we look for medical students going into residency. Pick a patient and anchor your learning with them. So we talked about like if you see a DKA patient, really try and focus your learning that night maybe about DKA. Reflect and stay well. So sub-Is can be a little bit hard, you know, like you're seeing a lot of patients, you're seeing a lot of shifts, but like it's also an exciting time. You might be in a completely new city, try and explore a little bit. And then know your counselors, know your resources. Like it's okay to be sad. The ED can be crazy. And like, please, please, please reach out to any one of us if you ever need help with like mental health resources or if you ever have any issues at all while you're on your rotation. And you should feel free to always talk to your like clerkship directors and staff to see what other resources they have. Remember, some shifts will be better than others. Sometimes you'll walk out and you're like, yeah, I did great. I did a lac repair. I diagnosed this person. Other shifts you're like, oh man, my presentations felt like a little bit of a hot mess and like this and that. But that's the beauty of the emergency department. Every shift you start with like basically a brand new team and you can start off almost completely fresh, to be honest. So like if it was a bad day, be like, tomorrow's going to be better. If it was a good day, be like, tomorrow's going to be even better than it was today. You know, like just continually try to improve and just know that every day will be different. And try and focus on the positives, but do take away the lessons from the not so hot moments. If you only focus on like, I did bad on this, I did bad on this, that's going to be really depressing and that's not a way to improve. But instead, if you're like, I could have done better on my presentation, let me look up a way to present better, or let me come up with a broader differential next time. Like try and continuously improve and look for ways to do things differently. All right, great. So those are kind of the majority of the tips that we have. Just a little bit about Harbor UCLA. If you're still looking for sub-I spots, once again, we have them in the fall and the winter. We have lots of ultrasound spots available as well. So feel free to apply on I can't say the acronym. The Visiting Students Learning Opportunities, VSLO. And always feel free to reach out to Manny, to our DEI email, which I'll put at the very end if you're interested in chatting more about rotations. Harbor has about 550 beds. We're a level 1 trauma center. We see peds trauma, peds critical care. Our patients are about 60% Latino, 18% Black, and then a smattering of other ethnicities and races. About over half of our patients have are English language learners, so non-English language preference. I'm going to change this slide. So that means that mass majority of our patients end up speaking a lot of Spanish, and I'll show you the chart in a little bit. And for those of you who are not from LA, this was very confusing to me because I'm also not from LA, but there's 3 different emergency medicine residency programs within Los Angeles proper. There's us, so LA County, Harbor, UCLA. We're down here, and this is our catchment area. So we're in the South Bay of Los Angeles. There's LA County General, LAG, or formerly known as LACUSC. They're kind of up here. They take care of more of East LA. And then the last one is UCLA, which is a fusion between county as well as academic. And so they're Olive View as well as Ronald Reagan as well. So they're kind of a fusion site. But all three of the programs are different. We do have like all LA conference where we work all together, but those three programs are a little different. And that's about it. I need to update this slide too. That's a lot of me talking. Thank you for joining this journey with me. There is a bunch of things in the chat, so thank you all for asking questions and kind of responding to questions. I would like to open it up also for questions from anyone, as well as if any of the Harbor folks have any other additional tips or want to elaborate on anything from the presentation, that would be lovely.
I can jump in with a couple of things while folks are thinking of questions or putting in the chat. Thank you, Joyce, for that great overview. I highly encourage you, as you're rotating, really getting to know the place that you're at within and outside the hospital, especially if you're seriously considering going to that program, and with that also get to know like the residents, the program. There'll likely be like several hangouts for you to join. And then I put this in the chat, get to know, especially if you're at a place like Harbor or whether you're at like a more quaternary hospital, what are some of the resources and other support that are available? Like we have social work, we have trauma recovery center, things like that. Like for me personally, were really important as I was thinking about it, because like my ER encounter is very limited, but like what are the things in the way, like what are other ways that we can help support patients?
I think echoing that, if you have any special interests in any parts of like non-clinical parts of medicine, like food insecurity or like substance use disorders, like let us know early on, and maybe we can connect you with a resident or faculty member who is involved with that line of work. Like for example, at Harbor, we have a food pharmacy, we have different like substance use disorder resources. There are many other different things that you can get involved with.
That's funny, Tiff. That was actually what I was just about to say. But kind of echoing that, I met one of the assistant medical directors while doing food pharmacy, unknowing to me, which was actually like really cool and humbling. There's also like opportunities to come to conference as well. We're shifting a lot more to in-person conferences, which has been, or we're hybrid, in person and virtual, but we're doing more in person now. So that's also an opportunity if you want to get to know us outside of a clinical setting too.
Great. Any other comments, questions, complaints, concerns? I see there's a little bit, I was reviewing the chat. People were chatting about Wickham. Yeah, Wickham is a fantastic resource. I could share my screen to actually show you what it looks like. So if you just literally type in Wickham and then you pull it up, you can kind of search anything. So say, for example, like you have a patient that you're diagnosing with like a urinary tract infection. Also, the search bar here doesn't work as well. So I usually actually just put it into Google, say Wickham, and then say whatever I'm actually going to search. Like, okay, cool, acute cystitis. And so it gives you a abridged version of up to date, be like, okay, definitions, what are risk factors you want to consider, reviewing micro, things, the differences between uncomplicated and complicated. And the thing that's really, and then your differential, which is nice. So if you're like, oh, I think it's a UTI, but maybe they're pregnant with an ectopic. I don't know. And so it has a bunch of different things to think about. And then at the bottom, it tells you what you want to do for your evaluation. So what labs you want to order, as well as the management, and actually has the dosing as well. If you tell us dosing, I would be very impressed. I was never able to, I was so bad at that as a medical student, but if you're like, I want to order Cufflex 250 QID for 5 days. I'll be like, wow, that sounds like a great plan, you know? So it can help you a little bit with your dosing as well. And then there's a section on MDMs as well. So Wickham MDMs. So medical decision making, this is something that's unique about emergency medicine notes. We don't have these like really long assessment and plans, but we want to think about our thought process. This I would say is more of like a starting point for you to think about how to write your MDM. Don't necessarily just like blindly copy it because every patient is different and you really want to be thinking about what you're actually doing for the patient. But let's say like, okay, this patient has rectal bleeding. Be like, okay, rectal bleeding most likely due to maybe think it's hemorrhoids. Low suspicion for like X, Y, and Z things, but it's not an emergent thing, no evidence of hemorrhagic shock. So this would be an example of like a really kind of shortened MDM. So you can elaborate and make it more specific based on your patient, but it can give you a starting point on how to write your MDM. And there's a whole bunch of them you can kind of look through here. So like dizziness, for example, like low risk dizziness, we think they're going to go home. High risk, they need like an MRI or they need to come into the hospital. So it helps kind of think about things from an an EM mindset. So definitely use Wickham. And then here's our little foundational sponsor. That's us. Cool. Other questions, comments?
One question that did pop up was regarding if you're doing like a ped sub-I, ultrasound sub-I, or just your general adult sub-I after interview season, if you're still eligible for the sub-I interview, which I think you are, but I just want to clarify.
Yeah, I think every program does it a little bit differently. At Harbor, if you do a sub-I with us, you have a guaranteed interview. Doesn't matter when the sub-I is, like you're ready, like guaranteed to have an interview. And I know a lot of programs do that. Sometimes they have you, other programs will have you interview actually at the last day of your rotation. So you might be like rotating in June. It'll be your like very last day, be like, it is time for your interview. And you're like, what? But usually it's a little chiller because they knew you from throughout that whole month-long experience. That's going to be your, honestly, your like main interview. I know that some people call them like audition rotations and things like that, which is fine. We usually call them like sub-Is or sub-internships here. But yeah, if you rotate with us, we will give you an interview. Great. Other questions? I'm like trying to keep up with the chat. If other people that are monitoring the chat want to chime in, or feel free to unmute and ask other additional questions. Let's see. Yeah, so question from Kelly. What should we bring to our sub-I? Some provide scrubs. Do we all bring gear? Things like that. Yeah, every rotation is definitely going to be different. Definitely pack scrubs, like your home institute scrubs is going to be great. So bring scrubs with you. If you can get shears, it's helpful to have shears, like trauma shears. You can get them for like $7 on Amazon and just like stick them in your pocket, have them ready to go. I think that's very helpful for an emergency rotation. And then otherwise, like stethoscope, pen and paper, those would be like the top things that I would have with you on shift, ready to go. Anything else from anyone else? Maybe if like your cell phone, if you have your little apps downloaded too.
A pen light also.
Yeah, that's something I always wish I had, but should probably carry.
Joyce, I bought a pack of 4, so I'll give you one next time.
I would love one. Thanks, Tiffany.
I think there's also a question from Tushara. Joyce, I don't know if you could answer this question a little bit better.
Yeah, so it looks like if we have interest in the outside of clinical aspects of EM and are looking to dip our toes in even before our sub-I, would it be okay to reach out for advice and opportunities? Oh, it's a good question. Leolia, do you want to take a stab at this, or otherwise I can try and help answer it?
Sure. I mean, I think I can't speak for other institutions, but I think for the most part, our faculty, I shouldn't say for the most part, our faculty are very like welcoming to like talk to people about interest, possible projects, and throughout like application cycle. And even like if you're even if you're deciding between different programs. So I know for when people are rotating, I help with the sub-social EM curriculum. We give different opportunities for people to volunteer at different programs, but I don't think there's like any harm in reaching out to faculty. If anything, it's indicating your interest and also telling of the program if they're willing to speak to and mentor students. Does that help?
Yes.
It was a little vague, but encouraging you to do it.
Yeah, if there's something you're interested in, I don't think anyone would ever fault you for reaching out. And you don't have to do it, but like it could be like something a little bit proactive that you could do. For our program in particular, at the start of your rotation, we will assign you a mentor, both a resident and a faculty mentor. And the goal would be to meet at least once in the beginning, maybe once in the middle or end, to kind of prep you on the rotation and also have a point person to ask questions to. So I know the rotations might either pair you up formally or informally, but really try and find those mentors that are out there. Because a lot of people are interested in like medical education and really helping students. So ask those questions. Like we wanna help in any way that we can. Cool. We got 7 minutes left. Other questions? Anything of the sort? Love me some Zoom awkward silences. It's great. Either unmute, put it in the chat. Thanks. Ooh, favorites food spots. Who wants to take this on? I love food. So please someone else talk instead of me.
I have so many favorite food spots. Like once you guys come, find me. I will send you my list, so I made like a little notes app list of favorite food spots since I'm from LA and I went to school in LA and know the area really well. I sent it to one of my co-residents who then sent it to the entire IM department. So like to the point where I was calling for an admission last year. They're like, hey, is this Tiffany the food list girl? I was like, oh my God, am I a food influencer now? Am I famous in this hospital? Anyways, let me know when you're in town and I'll let you know where the spots are.
Can I also get that food list?
I know, me too. I would trust Tiffany for any and all food advice. Absolutely. I would say South Bay has a lot of really good spots. There's like a French bakery called Sweet Wheat, which is in Redondo, and they have like fantastic bread and pastries. There's a really good Italian spot called Fatto a Mano, which is like this little Italian couple named Marco and Arlene who have like 6 tables and their food is like fantastic. There's a lot of really good Korean food in Torrance, and lots of really good Asian food overall. LA has good Mexican food also. So lots and lots of places to eat. Like when you come here, we will give you lots of lists. Oh yeah, and we have our class has a group called Taste Buds, which is kind of cute. But Leolia put the link to it, and it's honestly overwhelming the number of pins that are on this Google Maps. But feel free to click on it. Cool. Other questions? Once again, please, if you have any questions at all, like reach out to us. I'm putting our Harbor EM DEI email in the chat. Me, Leolia, Natalie, we watch it. We're onboarding Caesar as well. So I'm gonna tell you about this email, but you're gonna be watching it too. So feel free to ask us any questions whatsoever. We'll end just 4 minutes early so that you can go enjoy your Wednesday afternoon / evenings. And just reach out with anything. I hope this session was at least a little bit helpful, and thanks for joining. Bye, everyone.